Good morning, everyone.
Morning.
Thank you for joining our Bpan clinical session this morning. I'm going to introduce our speakers. The first speaker on our panel is Dr. Susan Hayflick. Dr. Hayflick is a professor of molecular and medical genetics, pediatrics, and neurology at the Oregon Health and Science University in Portland. She has dedicated her research career to advancing knowledge of NBIA disorders with the goal of curing them. For over 30 years, her team has become known internationally for its clinical and research expertise in all NBIA disorders. She's authored numerous articles about NBIA and has been awarded national and international grants to study those conditions. Her lab, in collaboration with partners worldwide, discovered the PANK2 gene in 2001, the PLA2G6 gene in 2005, the FA2H gene in 2010, WDR45 gene in 2012, and the MECR gene in 2016. These 5 genes account for about 90% of NBIA cases. Her team is now focused on developing therapeutics for several NBIA disorders and preparing the NBIA community for clinical trials. This is her 11th NBIA Disorders Association Family Conference, and she directs the Scientific and Medical Advisory Board for the NBIA Disorders Association. Welcome, Susan.
Thank you.
All right, our next speaker is Dr. Penelope Hogarth. Dr. Hogarth is an associate professor of molecular and medical genetics and neurology at Oregon Health and Science University in Portland. She completed her medical school and neurology residency training at the University of Colorado. Following a fellowship in movement disorders and clinical research trial design at the University of Rochester in New York, she moved to OHSU, where she joined the Hayflick Research Group shortly after the PANK2 gene discovery. She's maintained a deep commitment to the NBIA field ever since. She played a key role in finding the Bpan gene and led efforts to establish the Bpan-ready natural history study and biorepository. She has a particular interest in designing clinical studies that remove barriers to research participation. In addition to studying NBIA, Hogarth's research interests extend into Parkinson's disease, Huntington's disease, and other movement disorders. She is a member of the NBIA Disorders Association Scientific and Medical Advisory Board. Welcome, Dr. Hogarth. Our third panelist is Dr. Jenny Wilson. Dr. Wilson is an associate professor of pediatric neurology at Dornbecher Children's Hospital, a teaching hospital associated with Oregon Health and Science University. Wilson completed her medical training at Stanford University and the Children's Hospital of Philadelphia before joining OHSU. She practices general pediatric neurology with expertise in tone abnormalities, movement disorders, and developmental disabilities. Wilson began working with the NBIA Cure team in OHSU in 2017, participating in the NBIA clinic and on research projects. She also directs the tone management program at Shriners Hospital for Children in Portland, OHSU's neurodevelopment program, and OHSU's pediatric stroke program. Good morning, Dr. Wilson. We're also going to be hearing from Dr. Laura Adang. She is an attending physician in the Division of Neurology at Children's Hospital of Philadelphia, specializing in genetic demyelinating disorders. These are conditions that damage the protective covering, the myelin sheath surrounding the nerves in the brain, optic area, and spinal cord. Her research is focused on clinical trial readiness for rare neurological diseases, specifically focused on disease-specific outcome measures and the development of biomarkers, biological measures that can be used to measure the presence of progress of disease or the effects of treatment. Welcome, Dr. Adang. We're also going to welcome Dr. Itai Bushlin. He is at Oregon Health and Science University and OHSU's Dornbecher Children's Hospital. He specializes in caring for children with neurological problems, brain, spinal cord, and nerves. He has advanced training in pediatric epilepsy, including managing seizures, reading EEGs, and preparing children for epilepsy surgery. Sometimes seizures are associated with genetic changes that are either inherited or new child. Bushlin helps families understand how a child's genetic results may affect seizures and treatment. Welcome, Dr. Bushlin. And last but not least, we will be hearing from Allison Gregory. Allison is a certified genetic counselor who completed her undergraduate work at Stanford University in human biology and received a master's in human genetics from the Medical College of Virginia, Virginia Commonwealth University. She has been a board certified genetic counselor since 1996. Gregory worked in prenatal diagnosis for several years in Southern California before joining the Oregon Health and Science University in 2002. She is an assistant professor in the school's Department of Molecular and Medical Genetics. Gregory has worked in the Hayflick Laboratory for 18 years, studying NBIA. She develops and implements and manages clinical research projects, assists with writing scientific papers and grants, and serves as a support and resource to all families with NBIA. Welcome, Allison Gregory.
Thanks, Amber. I see lots of familiar names on the participant list. We're really happy to have you all here.
Yes, and without further ado, I hand it over to our panelist of researchers.
Thank you. So everybody knows our format, I'm going to manage the list of questions that you all submitted over the last few weeks. And the Bpan group by far gets the award for most questions submitted. I hope that our 2 hours is going to be able to cover it all. If it doesn't, we'll follow up and catch up with you later. I did take the liberty of combining some questions and trying to make sure that we were doing this efficiently. So just so panelists and participants know, I've divided the questions into 5 categories, including like littler kids and older kids. So I'm going to hop around between the categories so we try to hold all of your interest, because I know some of you have little toddlers and some of you have adults with Bpan, and we want to make sure that we're covering the spectrum as we address these issues. And I will call on the panelists. All of you are welcome to chime in, even if I call on one of you first. We just want to try to kind of manage the process here. So I'm going to start with a basic one that I do think affects a lot of people, but maybe younger kids more than older. The question submitted was, what is the best sleep aid for kids with Bpan after trying at least 8? This is still a struggle, and it's a common one. I'm going to ask Jenny and Laura to address that one first.
Yeah, that's a tough one. I think this is kind of sleep is a big challenge in Bpan, and sometimes it's trial and error going through a number of different medications. But I guess, taking a step back, usually what we're doing is looking at the kind of overall sleep situation and looking at environmental factors that might be impacting sleep. Are there any things like discomfort that might be going on, anything behaviorally we can change or address? And then looking at the sleep itself, just asking about, okay, well, is there snoring? Does a child need a sleep study to evaluate for sleep apnea, which might be disrupting sleep? Is there any clinical concern for seizure? Looking at, is there a restless sleep? Sometimes kids get restless leg syndrome. And, is there another reason why the medications aren't helpful at all? But there isn't one best sleep aid. We just generally try to start the kind of least worrisome medicine, or the one with the least side effects, like melatonin, and gradually move up if needed.
Yeah, Jenny, we train together, so we're in alignment on how to manage things like sleep. I think it can be a really major problem that can affect a child's functioning the next day if they're getting insufficient sleep. And so I agree with everything you've said. The only thing I would add in would be considerations of things like autonomic instability. A lot of times children, when they have myelination abnormalities or differences in their brain, their body has difficulty regulating things like temperature overnight. And so it's really common for that temperature instability to be a cause of sleep disruption. And so even if it's winter, if the child becomes overheated at night, it's okay to put on things like fans. And so you really should be listening to the child's internal temperature much more than what you would be comfortable at night. I think that that's something that oftentimes can help with sleep. The other thing would be if a child has a G-tube and it's overnight feeds, sometimes adjustments in the rate or how the feeds are being delivered at night can help with sleep. And then tone management is critical too. Oftentimes we give medications regularly during the day, and so it's not uncommon for tone to increase at night during that longer gap in tone management. So that's the other big thing that I look for too.
Thanks, Laura.
There are some suggestions coming into the chat. And so we learned yesterday in the Pecan group meeting that families themselves have really some great solutions that they've come to. And so I would encourage, if you tap on the chat icon at the bottom of your screen, your Zoom screen, the chat box will open and you'll be able to read what other people are contributing there.
Thank you. Yeah, weighted blanket, I think, is a popular one and one that's appeared there already. Shifting a little bit to adults, I'm going to direct this one to Susan and Penny. And there were a lot of questions in this vein. Now that more time has passed, is the thinking still that regression will happen in the 20s to 30s in Bpan? What has been learned about this regression period?
You want me to start, Penny? You want to start?
Sure, go ahead.
Yeah, so this is an important one. So let me just remind you a little bit about the history of our knowledge of Bpan. So the way that we were able to find the gene in collaboration with others was to take a group of people who looked like they had a very, very, very similar condition. That is almost exclusively adults with what we now know to be Bpan. And what we were looking for specifically in order to find the gene was iron in their brain, and they had developmental disabilities, maybe seizures through their childhood, and then they had the early onset of Parkinsonism. And so we were looking for people who looked like each other in terms of their disease progression. That helped us find the disease gene, and then that was kind of all we knew. And so it's not so long ago. Amber told us when the gene was discovered. I can't keep track of those dates anymore. But since then, and for most of you, and with the advent of genomes testing in earlier for clinical purposes and in earlier life, most of you have children who are younger and haven't experienced that phase yet. So the important point about that is that you are going to teach us a lot of things that we didn't know. You already have taught us things. Your children have taught us things that we didn't know. And that's a really important point. So answering the question, May of 2021, we can tell you only what we know, and we may learn things in 2 years. This is one of the values of the prospective natural history study, the forward looking, not looking backwards and telling us how things went, but looking forward and telling us how things are going in an ongoing way. So what we know is that there is kind of the bulk of people with Bpan, and Bpan is a very varied condition. So some people are much more mildly affected, much more severely affected. And within that group, there probably will be a difference in when the Parkinsonism takes hold, when the regression begins. So we've said early adulthood, some will be later, and we know that some will be earlier, as early as the teens, for some as early as the later part of their first decade So 8, 9, 10 in that kind of a time frame. One of the other aspects is that parents of those, that first group that helped us find the gene, the parents didn't know that there was this thing called Bpan and that their kids might regress, but you all do. And so you're paying very close attention to your children. We all do anyway, but you're actually looking for signs of regression, as most parents naturally would be doing. And so you are more keyed into that possibility, and therefore a much more, I would say, much more attuned person. And that will also be something that probably reveals regression sooner. And we might see that there's actually a slower, more gentle tail leading up to regression that we hadn't known about before. Penny?
Yeah, so I would second that. I think that our knowledge is very much expanding, and this is an active area of interest and research. And we know it is a very emotional and very real concern to families. I would say it's probably one of the number one concerns that we hear is this fear of regression. I think that has two sides to it. This attention to when something might be happening is going to inform us and allow us to get a much more accurate and refined idea of exactly what that range is, so we can give you, the community, that information. But I also think it can have negative effects, negative impacts on the family. If you are super vigilant about looking for signs of regression, I think that's a burden, and it is an ongoing source of anxiety for families. And I don't have a solution to that, but except to platitudes about living in the moment. But one thing that I think we are coming to realize is something that we hypothesized early on, we proposed early on, is that the more severely affected the child is, I think the likelihood is greater that we will see the onset of Parkinsonism earlier in those children compared to very mildly affected individuals. It is also possible, we now know that there are some people, very rare, but there are some people with Bpan, because of the complicated genetics of this disorder, who are incredibly mildly affected. And quite honestly, we don't know if they will ever develop Parkinsonism. And I think, again, as Susan said, with the prospective natural history study, we will get a better handle on that. One other point I'd make, even though it's a little bit of a sidetrack, not completely, early on, because of the way that we discovered the gene and the group of folks that we were looking at, we had the sense that the iron accumulation that we see on imaging was loosely correlated with, attached to when Parkinsonism started. And two things have happened in the intervening years. Not so many years, but nonetheless fast-moving ones. Most importantly, I think, is our methods of imaging iron have become ever more sophisticated and sensitive. And so we now see that iron is there really quite early, certainly in the first decade of life, and sometimes just in the first years of life. And that does not correlate with when Parkinsonism starts. And so that's just one issue I want to put to bed, because I think it is something that families, again, get pretty focused on. If they hear there's iron on their 6-year-old, 7-year-old, 8-year-old child's brain imaging, they fear that that means their child is going to show signs of Parkinsonism the day after that scan. And that isn't at all the case. So just to put that issue to bed.
Thanks, Penny. I actually have another question that dovetails nicely with that I'm going to direct to Susan, which is, what is the concern with iron accumulation? How can we stop iron from accumulating, or are there any treatments, or is that necessary?
Yeah. So the answer is there hasn't been the right kind of clinical trial done to answer that question confidently. So what we're going on is our best understanding today of what the disease process is, what the biology of Bpan is. And a little bit about what we know about Bpan is comes from what we have learned from studying the brains of individuals with Bpan who have died, and their families have made the choice to donate those brains for studies. And from those, what we know is that, yes, there is iron accumulating, and it's accumulating in the same parts where it accumulates in the other NBIA disorders. But Bpan is a whole brain disease. So whereas PCAN sits just where the iron problem is, as far as we know today, Bpan is everywhere in the brain. And the reason that's important is that it's not just everywhere in the brain, but it also is, there are quite significant changes throughout the brain. There are changes similar to those that we see in Alzheimer's disease, changes similar to those we see in Parkinson's disease, and they're extensive throughout the entire brain. And so remember, the biology of Bpan, as we understand it today, is that this autophagy, the cell's natural system for recycling its parts, breaking them down and sending to the trash what goes to the trash and reusing what it can reuse, is impaired. And it probably becomes more and more impaired over time as more, if you will, trash builds up, more of the sort of the refuse of the cell builds up. And so iron is part of that story. There's a paper out just this morning that gives, I haven't read the paper in detail, but from the initial look, it gives some links. It puts links together between autophagy and the iron accumulation, and that's helpful. But it's only one sort of stream. It's the stream that we can see most easily on the MRI. So it's a long-winded way of saying that we may be able to control the amount of iron, diminish the amount of iron through what we call a chelator, a chemical sponge that takes iron and helps the body pee it out in the urine. We may be able to decrease the iron, and that may impact some aspects of the disease. But I believe that even with very effective iron management, there would be a very significant disease in Bpan, including the regression. I don't think the regression is from iron. I think it's from the primary problem in Bpan. And so what we have always done in our group, in the OHSU group, is we have never focused expressly on the iron as a treatment target. We have always focused on the primary problem. That's why we aren't gene hunters because we're totally into genes. We're gene hunters because you have to know you have to know what that first domino is. And so in finding that, we are able to know what the primary problem with the disease is, and then that's our target for trying to develop therapeutics.
Thanks, Susan. I'm going to shift to a seizure question for Atai. I think this applies to a lot of families, especially as kids get older. How do you decide when and how to try to wean off seizure meds? Are there certain factors or bars that you're trying to meet before you embark on that?
Yeah, that's a great question, and oftentimes it's a very individualized response. So there's a lot of variability between child to child, and some of it depends on how severe their epilepsy and seizures have been historically and kind of where things are going. Now, typically, with Bpan, there's a wide variety of different seizure types and age of seizure onsets that can occur, although typically it starts quite early in life in the first couple of years, for at least from the cases that have been published. But a lot of children have better control over their epilepsy as they get into their adolescence and the adult years, and that raises the question of, is that an appropriate time to come off of seizure medications? And if so, how do we make that medical decision making together with families? I think a good rule of thumb for most epilepsy doctors is that we like to see kids at least 2 years seizure free off of while still on medication before we consider kind of weaning off medications completely. And part of that is seeing, on EEG if there's still a really severe risk for seizures before we wean off medications. But in a child who's not had seizures in a few years and whose EEG isn't showing a high risk for seizures, that may be an appropriate time to try to come off of seizure medications at that time. It's a little bit of a separate question from, when do we change track with seizure medications, like in the middle of treating epilepsy when epilepsy is still not well controlled. And that comes down to how effective do we think the medication that we're using is, and what side effects is it causing, and is there potentially a better choice that we could consider?
Thank you. Shifting back to the littles, I'm going to direct this to Jenny and Laura again. Some kids with Bpan have either heavy breathing or breath holding behaviors, and families are wondering how to approach this or how aggressive they should be about treating it. It's definitely more problematic for some than others.
I'll be happy to start with that. So I think part of the critical team in caring for any young child with Bpan is having a pulmonologist on board, to really making sure that there's not an organic etiology to the difficulty breathing. That's step one. But I agree. I think many children with Bpan have the behavioral changes that are resulting in them doing breath holding spells and things like that. For breath holding spells, a lot of it is behavior management and making the child feel comfortable. I've found in many of my children, those events are increasing in times of anxiety, as one would see in a more traditional autism spectrum disorder. And so I think having a behavior management plan on board is really helpful for helping kids when those breath holding spells are coming more from a behavior stimulus or an anxiety stimulus. Jenny, what are your thoughts on the management?
Yeah, I mean, honestly, I think it's tricky. And these are, I mean, the kind of hyperventilation and breath holding that we see in Bpan, we see in other disorders and other kids who have developmental disabilities. So it's not necessarily unique to Bpan. It's hard to treat them medically, I will say. And so I guess the first question is like, well, are these a problem or not? Are they just distressing the child? And as Laura was saying, is there, something that's kind of triggering them that's painful or upsetting that might need to be addressed? But yeah, I guess the question is, are they causing problems because we don't have like a perfect treatment? There isn't like this easy, great medicine that just takes them away. So if they're not causing problems, it may be perfectly fine to just kind of ride it out. And if they're really problematic for a child, like it's affecting their GI tract because they're swallowing a lot of air, and that's really pretty significant. Then there are some medications that people try, but I think the benefit can be fairly limited with it.
Thanks, Jenny. And then we had a follow-up question from the chat that I'll direct to you and Laura also about the autonomic function issue. The question is there specific testing recommended to evaluate this? We've got a child who during the night has sleep-wake seizure-like episodes, oxygen desats, spikes in heart rate. How do you recommend that parents approach this? Should they be doing formal evaluation? What should they be looking for?
Yeah, I mean, I guess first question would be, are there seizures? I mean, we're much better at diagnosing seizures than we are at diagnosing autonomic dysfunction. Our autonomic nervous system drives a lot of different things for all of us, and saying whether that's working properly or not we don't have a great test of that. I think it's kind of a term we use when we see that the heart rate's going up and down, the blood pressure is going up and down, the temperature is not regulated well, but we don't have a great measure of autonomic disturbance, so to speak. So, and nor do we have a specific treatment for that. It's more of a description of what's going on. So I think the first step is, well, are there actual seizures? Because that we are good at diagnosing. And if there is a concern for seizures, then we can do an EEG and sort that out. And so that'd be step one. And then beyond that, I think we can use the term autonomic dysfunction at times, but it's really not a clear diagnosis.
Thank you. Penny, I'm going to direct this next one to you. I think a lot of families struggle with this because it happens gradually. The question is, what does Parkinsonism look like? And when does someone need to start treatment for it in Bpan? How can meds help?
Yeah, so Parkinsonism is, I think, not so commonly evaluated in children. And so I think the list of people who recognize Parkinsonism in children is probably shorter than in adults. That said, I will primarily direct my comments to in adult patients with Bpan. And so in straightforward Parkinson's disease, what we typically see is a tremor at rest, more on one side of the body than the other, much more in the way of asymmetric symptoms, some stiffness, rigidity, a tone abnormality called rigidity, and then gait and balance disturbances, so difficulty with walking, a change in posture, and very much a change in balance. That contrast, it's similar to, but in Bpan, things look a little different. It tends to be much more symmetric, not universally, but generally so. I think it is a more symmetric Parkinsonism that we've seen in early adults, late teens. I think dystonia is much more common, as is the case in most younger onset Parkinson's-like syndromes. We tend not to see so much in the way of a typical Parkinson's tremor. And so that's one important point, is that if you are looking for tremor as evidence of Parkinsonism, you're probably not going to see that so much in Bpan. I think the thing that we are learning in the natural history study, and this is a really tough one, is that sometimes sort of the first signs are that an individual's kind of level of activity and interest in things starts to change a little bit. Sometimes we have young adults who have been engaged in a sort of protected activity or work settings, workshops type settings, and whereas they've always enjoyed a particular activity, a particular video, a particular activity with the family, now it is just so much harder to get that person to enjoy those things. They seem to be less interested. And following on the heels of that, the family might start to see some slowness of movement and really quite early some changes in balance and walking, I think, are the most common things. You might start to see a foot twist, turn inwards. I think those are probably the most common things that we're hearing about. The behavioral stuff, the loss of interest in an activity that previously was very engaging, is a tough one, because I think that's another thing that can make families really paranoid when you're dealing with a teenage, intellectually disabled population. That stuff happens. It happens in the non-intellectually disabled population too. Kids have mood variation, and things happen, things disturb them. This last year has been tremendously disruptive to children and adults, all ages, all abilities, And so, I think that's been very hard to judge. So I don't want to send the message that if your child loses interest in something they were previously excited about, you should worry. But this is a very persistent change, a very discrete change. And that is often the first thing that we are hearing from families, I think. And then what to do about it? I think when Parkinsonism starts, if your care team does not include a neurologist with some comfort and expertise in the management of Parkinson's disease, that is something that I think is a key part of the management team. The challenge of medication management once Parkinsonism starts is quite difficult in Bpan, or can be as the disease progresses. And I think the involvement of a movement disorders doctor or a neurologist who's very comfortable with Parkinson's disease medication management is going to be really key.
Thanks, Penny. And can I also ask you to address, there's a really good question in the chat about this as well. Someone who's trying a Nupro patch rather than oral Sinemet, and it's working really well. But do you know if the risk for dyskinesia is the same with the patch?
Yeah, it's a really good question. So this is getting a little bit into the biology, but dopamine is in its natural state in people who don't have, well, just in the human body. Dopamine is a neurochemical that is designed to be delivered continuously. And what medicine does is it's a very poor mimic of that. We deliver doses of medicine at intervals, and so we see dopamine levels rise and fall in the blood when we do that. The more advanced a person's disease is, the less reserve they have to cope with those fluctuations of drug levels, of dopamine levels. And that shows up as this, what we call fluctuations, where the person goes from being very stiff and off to being, very on and maybe too much on. They're moving around, and or they may have dyskinesia or dystonia that is very problematic. It becomes harder and harder to kind of keep them at a smooth level over time. So there's always been interest, both in the Parkinson's community and now in the Bpan community, in can we deliver a dopamine stimulation in a way that is closer to what nature intended, which is tonically or continuously. So in theory, a patch system that delivers some dopamine stimulation continuously should be better than oral levodopa, which is our shortest path to making dopamine chemically. We've heard, I would say, mixed reactions. Don't have a whole lot of experience yet with some of the patch delivery systems and other continuous delivery systems. There's one that involves a tube system, a bit like a G tube, but delivers, it's called duodopa, and it is delivered to the first part of the small intestine. In theory, that might help with some of these big time fluctuations. And so again, the natural history study is helping us to try and delve into this, because your experience as Bpan families is going to tell us that. So it's very helpful to hear, hey, we've tried this and it's helpful. Sometimes the class of drugs that Nupro sits in, they're called dopamine agonists. They can also cause dyskinesias. And one caution is that I think the dopamine agonists, this class of drugs that Nupro sits in, is a little more prone to cause drops in blood pressure when it is first applied. And so for someone who is having trouble managing their blood pressure variations, that might be a bit of a challenge. But we're really interested to hear what people's experiences are. So thank you for sharing that.
Thanks, Penny. And this next one is for Itai. And I see this with new families who I meet. Sometimes there's a lot of confusion and they think they have multiple diagnoses because they've been given so many names. So they've been told Bpan, but they've been given another name for their seizure disorder. And, Maybe they also have cerebral palsy, and we have to kind of bring this all under the fold of Bpan. So the question is, how does Bpan cause Lennox-Gastaut syndrome or other seizures? And I think what it's getting at is, is this a separate disorder? Is this part of Bpan? And what might be going on in the brain that's causing this?
Sure. Yeah, that's a great question. Very common question, actually, that we get not from just folks who have kids with Bpan, but all other kinds of disorders. And it's probably a reflection of how we've changed our terminology over the years, where historically, we didn't have genetic testing, and we're able to make genetic diagnoses and kind of understand better about certain cohorts of people. And we kind of made these broader categories of seizure syndromes. And so just for basic kind of terminology terms, some of you guys will probably know this. Lennox-Gastaut syndrome doesn't refer to a specific genetic or one specific cause of epilepsy, but it's really a feature of a conglomeration of seizure types and kind of developmental issues and EEG findings that tends to come up in kids around age 2 or 3 or a little bit after, and is sometimes preceded by another sort of seizure syndrome called West syndrome, or infantile spasms. But the bigger picture is that things like West syndrome or things like Lennox-Gastaut syndrome can actually be caused by a variety of different disorders. So, for example, kids who have early strokes or prenatal strokes or congenital brain malformations, or things like Bpan, which are genetic causes for their epilepsy, may at some point in their lives have features that are consistent with these epilepsy syndromes. So West syndrome very early on in life, in the first year or two of life, or Lennox-Gastaut syndrome after that. And honestly, we don't completely understand the transitions between West syndrome and Lennox-Gastaut syndrome. What kind of is actually changing in the brain is clearly a developmental phenomenon, because Lennox-Gastaut syndrome seems to follow West syndrome, or sometimes Lennox-Gastaut starts all by itself without being preceded by West syndrome. But when we use the term Lennox-Gastaut these days, we're again really referring to a conglomeration of just seizure types. So things like absent seizures, so kind of staring spell seizures, or atonic seizures, seizures where people kind of drop their heads or their bodies really quick, or tonic seizures, stiffening seizures. And usually that conglomeration of seizure types plus some sort of developmental delays in a characteristic EEG finding is how we define Lennox-Gastaut syndrome. But again, it can be caused by lots of different things. So it's a part of that process of both kind of development. It's a developmental epilepsy, Lennox-Gastaut, but in Bpan, it's likely due to kind of the changing function of the brain over time as it's being impacted by what Dr. Hayflick was talking about, kind of accumulation of toxic waste products from impaired autophagy. And we don't have kind of better specifics on that, but where it's beneficial, I think, to still use the terms like West syndrome and Lennox-Gastaut syndrome on top of, whatever the underlying disorder is, like Bpan, is because historically folks have done clinical trials for seizure drugs for kids who have either that label West syndrome or Lennox-Gastaut syndrome. And so we tend to know what types of medications work better for each of those. And that's where those labels are still a little bit useful.
Thank you. And while we're on that topic, another thing that I hear families asking about is, how do those types of seizure syndromes that are more severe, like the infantile spasms, contribute to their long-term outcome? They start with Bpan, but then there's this other issue of ongoing seizures. What impact do those have?
Yeah, certainly they can be quite impactful. There's some variability there. It kind of depends on what type of seizures they are, how often they're occurring, and how early on they happen. But generally, kids who have earlier onset epilepsy, who have kind of a more severe epilepsy with types of seizures like infantile spasms, have the potential to be more impacted by their seizures on top of kind of the other things that Bpan is causing. And so that's why we do our best to treat those kind of seizures and to try to stop them in their tracks if we can. We're not always successful with that, but there are more and more treatments or combinations of treatments that people are studying these days for not just folks with Bpan and epilepsy, but all folks who have infantile spasms or Lennox-Gastaut syndrome. But certainly, yes, ongoing seizure activity can impair development. Sometimes the seizure activity is just kind of there and it happens, and a few minutes of seizure activity every now and then is probably not that impactful. Probably what's more impactful is if someone's having what we call an epileptic encephalopathy, which is really frequent abnormal brain discharges that are happening all the time and may or may not be coalescing into seizures, but are really occurring so much that they're impacting learning and development and that kind of thing. So it may actually not be the seizures that are as impactful, but kind of the between seizures phenomenon that could for some people be more impactful. Now I know someone asked earlier about kind of sleep and EEG changes during sleep. Maybe I can address that now. That's really variable. I agree with Jenny that, I think it's only probably worth looking at sleep if someone's having active seizures during the daytime, or, they already have poor sleep and we're wondering if they're having like silent seizures in sleep, or if they're having seizures that we're just not picking up in sleep. Just having an abnormal EEG during sleep doesn't necessarily mean that that's absolutely going to impact your day-to-day, but there are some EEG patterns during sleep that are on the more severe end of what you can see that could potentially impact your development. So I think for folks, again, who are having active seizures and having abnormal sleep, it's probably worth at least one point checking an overnight EEG to see what's going on.
Thank you. I'm going to ask you one more follow-up. So
Sure.
we do see kids who only seize at night or who seize upon awakening, and it can be in the morning or it can be from an afternoon nap. But can you comment on what it is about sleep that might be triggering that or helping to isolate seizures to those periods of time?
Sure. Yeah. We know if we really took everyone together as epilepsy, no matter what the cause, the most common times to have seizures are in the periods of time around the time of falling asleep and around the time of waking up. So plus or minus an hour or two in that region. So I don't know that we can pinpoint exactly what the biological factors are there, like that are totally underpinning that. There's something about those transitions that makes the brain a little bit more vulnerable to having seizures. That's a really common time for everyone who's epilepsy. Now, certainly you can have seizures during the daytime and seizures during sleep in the middle of the night, and so the seizures are not exclusive to those time periods of sleep-wake transitions, but those are the most common ones. Nighttime seizures are also possible in many folks too. I think they're often under-recognized because caregivers have to get their own sleep also. I think the more worrisome ones, so there's lots of different types of seizures, but the more worrisome ones would be folks who are having tonic-clonic seizures at night, so big stiffening, shaking seizures. And over time, parents and families have identified a variety of different kind of devices that they can put in a room to see if they can detect those, so like cameras or other detection devices. And that, I think that is probably reasonable, but I think if you're worried about your child having seizures in the middle of the night, it's probably worth talking with your doctor about whether any of those are kind of devices are reasonable, or if it's more subtle seizures that maybe we don't necessarily need to be aware of.
Thank you. Susan, I'm going to send this next one your way. How would gene therapy be expected to impact Bpan? Has this been done in similar disorders?
Okay, so gene therapy, just as a reminder, is introducing into a cell a new copy of the gene. So you're not swapping it out. You're introducing a new copy of the gene. I guess sometimes you are swapping it out, but and so what would we think for Bpan? The challenge with Bpan and gene therapy is that the disease as we know it today sits in every single cell in the brain. That is, in order to fully improve the disorder, we would need to have a new gene delivered to every single cell, or to at least a significant number of those cells. And that has been a barrier, that has been a challenge for gene therapy for neurologic diseases. So many of the diseases that are benefiting from a gene therapy or a gene editing kind of an approach are those that are targeted to either a specific part of the brain or spinal cord, or to a more kind of just a smaller group of cells. It's kind of it's a delivery issue, and then it's also it's a timing issue. So we don't know whether delivering a gene therapy to a person who has had Bpan for 10 or 20 years, we don't know whether, it's like with anything, we don't know how much healing can happen. We don't know how much recovery there can be. So these are important questions. The sequence will be, so there are a couple of mouse models out there of Bpan that are pretty good. I think they're complementary. And those animals, they showed Bpan-like disease widely spread in the brain. And I think that those animal models can be useful for taking some early steps in understanding whether a gene therapy approach, or frankly, an alternate way to deliver the protein. So there may be other ways to get the WDR45 protein delivered to brain cells, whether any of those approaches actually help, not just at the biologic level, but whether the animals are improved. If we see improvement in a small animal model, we would go to a large animal model. These are the requirements of the FDA, that we sort of do that next step, show that it's safe and effective, mostly safe, and then there are still many steps and a lot of cost in moving into early human studies. But I do think that we will start seeing in the next few years, we're already seeing it, there's already gene therapy trials underway, mostly for neurologic disorders that have focal or localized disease. But I think we'll start to see more and more activity in that area. And one of my hopes is that there is, for whole brain diseases like Bpan, that there is something of a kind of a plug and play. I hate to use that sort of trivializing term, but that somebody comes up with a delivery system, and that any gene can go in there and will be sort of on a fast track to approval, so that it's almost like you get the whole delivery system approved with the understanding that the gene will be swapped out for whatever the disease is. And then that potentially opens the door to a faster track to clinical trials of a gene therapy in people with a whole variety of whole brain disorders like Bpan.
Thank you. I had a question on my list that I've also seen come up in the chat now. So I'm going to direct this to Laura first, and then maybe Penny can talk about it for adults. Who are the key players to have on your medical team and at different ages as people go through Bpan?
Yeah, so I'm actually a leukodystrophy doctor by training. And so I started finding families with Bpan as we were sending this broad-based testing for our children who had non-specific changes on their MRI. And so I almost accidentally became someone who saw many children with Bpan. And as part of our core clinic, we have a complex care pediatrician. We have physical therapy, occupational therapy, and we have a physiatrist to help with tone management. And I think that that's just kind of a fundamental core. And then I think each additional person on the team should be matching what the needs of are for the child. So a child with refractory epilepsy might benefit from seeing a specialist epileptologist. A child with a lot of pulmonary issues or obstructive sleep should have a pulmonologist on their team. A child that struggles to eat by mouth should have a speech therapist, a nutritionist, and perhaps a gastroenterologist on their team. And so I think it's taking a core group of experts and then really individualizing that care. And as we're understanding Bpan to be part of this expanding spectrum, we're realizing not every single child has the exact same needs. And so the question is really going through this list. I think one of the most important things is finding a quarterback. So the person that's going to help organize this care, understand who needs to see your child, and also help you to triage as far as importance goes. Because when you see a group of doctors and each doctor has 5 to 10 recommendations, some of those things can happen over the next year, and some of them need to happen within the next week. And so having someone to help you organize and say, look, you really should go and see the pulmonologist in the next month, but that eye check, I think we can probably put that off for 6 months. And so I think having someone to help you navigate this system is a really important thing that, you know, centers can help you do, and having someone that owns your child's management and can help you navigate this really tricky, complicated world. You know, as children get older, I think tone management becomes increasingly important, and sort of movement disorder specialists and someone, as we talked about before, with an expertise in Parkinsonism. So I think, you know, my expertise as a young child pediatric neurologist, leukodystrophy doctor with expertise in things like development is complemented by someone who later in life can really help partner with me for the tone management as well as the movement disorders that we see. So
maybe I can just add to that. All of the experts here joined together under the leadership of Jenny Wilson and developed with other colleagues around the world a best practice guideline that is based on a consensus agreement among experts worldwide of how best to manage the care of people with Bpan. And that guideline is well along. I think Jenny's got it under a revision that has been resubmitted, and we hope that that will be able to be made public within the next couple of months. So we're really proud of that work. And I think it will help your families, and I think it will help your providers to have some framework for some of the care, emphasizing what Dr. Adang has said about needing to, always needing to customize the team to the individual.
And so I would echo that. I think Dr. Adang's points about, what you need is going to be somewhat dependent on your child. I generally, I would say most children with Bpan do have seizures, and I think they're sometimes underappreciated. I think an epileptologist is very often a key member of the Bpan team. And then in adulthood, as I mentioned earlier, I think having somebody who is either a movement disorders neurologist or is a neurologist who's deeply familiar with management of complicated Parkinson's disease is really helpful. We found in some, but not all, children with Bpan having someone with specific expertise in augmentative communication. This is a sort of a subset of speech therapists. So I think augmentative communication devices and sort of advice on that front can be really helpful when language and communication is such a core challenge in Bpan. I think it is one of the things that challenges families most of all of the range of things in Bpan that challenge families. The other point that I'd make is just that, just 2 years ago, I would have felt incredibly arrogant saying, you should have all these experts on your team, when a lot of people just don't have access to a major medical center that had those experts. And I would say this is something that the pandemic has done for us, is it accelerated virtual medicine in a really extraordinary way. And I think now people who are very remote can, without needing to load their disabled adult onto a plane and deal with going to a major academic medical center where all these experts are there in a multidisciplinary clinic. I think now a lot of that care can be accomplished virtually, and we have systems in place. I don't think that is going away when the pandemic recedes in importance. I think that medical centers have been pushed in a way to make that possible. And I think that it is an enormous benefit that has come out of the pandemic, if we're looking for bright sides to it. So now even those at a distance can have a multidisciplinary team, I think. So.
Thanks, Penny. We've got a couple of questions coming through the chat that I'm going to direct to you as well here. Getting back to your discussion before about Parkinsonism, a follow-up on dystonic storm. Is it related to Parkinsonism? Does it happen in Bpan? What is it?
Yeah, so dystonic storm is something that we have talked about and been challenged by, helped to manage in Pcan for years. That is where this other NBIA disorder, I think it is a much more prominent part of it. But we certainly do hear of dystonic storms in Bpan. I think it is, and I may be biased because these are the ones that I hear about anyway. It is a feature largely of Bpan once Parkinsonism becomes more of a challenge. Because it is tied in Bpan, I believe, in contrast to Pcan, it is tied in Bpan primarily to these really challenging fluctuations in dopamine levels. Once dopamine delivery, the natural version of it, is impaired, dystonia is one of the ways in which that manifests. Then we try and intervene by delivering dopamine in this non-natural way with medications, and that can be incredibly helpful, but it also brings these challenges of big time fluctuations. And as the disease progresses, that response becomes more and more brittle, more fragile, and I think the person can then get into a bad cycle of dystonia that can be aggravated by a lot of different things. Anything that sort of messes up the person's ability to take medications on a very regimented cycle can do it. But so too can illness, infections that haven't been detected, the same kinds of things that we worry about in Pcan. So the first order of business is to see, is there something that is precipitating the crisis, to try to figure that out. We recently have had somebody who had essentially a dislocated joint that hadn't been detected, and that really tipped them into a person with Bpan, that tipped them into a dystonic crisis that had to be managed in the inpatient setting. So similar to what we've seen in Pcan in that respect.
Thanks, Penny. I've got one more question for you here. What is the biggest risk for people with Bpan as adults in their 30s plus, especially if they've been transitioned where they're not living at home anymore? Are there tips for their caregivers? What should they be trying to avoid, or what should they be looking for?
Yeah, so the care of Bpan in an adult patient who has pretty advanced disease, it has a lot of commonalities with the care of any very disabled person. I think the risks to the person's life, probably the most common risk is aspiration and injuries from falls. So to the extent that we can try to prevent those things or lessen the risk of them, I think that is one way to try and keep your loved ones safe. So if they are aspirating and consideration has not yet been given to a G-tube, to an alternate method of feeding, I think that that's the time to definitely be thinking about that, preferably before they have their first aspiration pneumonia. But even after G-tube placement, it's still possible for a person to aspirate on saliva. And so I think, consultation with the person's providers to try to mitigate risks of aspiration are going to help to keep them out of trouble. Positioning even, things like, so infections are a risk, whether that is from aspiration pneumonia, from breakdown of skin from somebody who is very immobile and develops what is usually called a bed sore, but it can sometimes be a wheelchair sore too. But area of breakdown of skin can quite quickly become a big problem with an infection that can take a person down in a big hurry. And so urinary tract infections, I think, are a common problem. So to the extent that each of those can be addressed, really good skin care, careful attention to secretion management, positioning, and then trying to prevent falls, because I think falls, even if they can result in quite serious injuries that might threaten the person's life and always impact the person's quality of life. It is tough to do that when you've got somebody who is living in a facility. It's tough to do it when the person is living at home with you. The most perfect caregiver in the world can't prevent everything. And I think that that's something that people struggle with. Sometimes these things will happen. And just being attentive to a change in status of the person who may not be able to communicate very well, and getting medical help early, I think is an important thing.
Thanks, Penny. Jenny, I'm going to send this next one your way. In previous years, when we were all meeting in person, we would hear a lot of teeth grinding going on in the room, which can be, problematic or not to certain kids. But do you have any suggestions for what to do if intervention needs to be done for teeth grinding?
Yeah, I mean, I think often I find it very variable in terms of how bothersome this appears to be for some kids versus others. And I do have families who, aren't too bothered, or the child doesn't seem too bothered by it, and others where it does seem to be more bothersome. I think, making sure there's a good dentist involved to check the teeth is important. Looking for triggers, if there are any specific like behavioral interventions, or is the child having any pain that might be bringing on episodes of grinding, or can behavioral interventions be used to decrease the grinding? And then there are medications for grinding, but they're not that great. So probably not too excited about trying that. There might be kind of dental type appliances, but I generally don't think those are super successful. And then occasionally in cases where it really seems warranted, you can do botulinum toxin injection to the jaw muscles to decrease it, but depends on how, how severe it is.
Thank you. And then I see in the chat, Laura, did you want to add something about the breathing abnormalities, or was it another topic we were circling back to?
No, it had to do with adult care.
Okay, thank you.
I wanted to add in and agree with everything Dr. Hogarth had said. I think oftentimes we can learn from our pediatric colleagues on how to help complicated adults. And I think people like physical therapists and seating clinics can add in a lot on like proper adaptive equipment to help adults as well. And then bone health, I think, is a really important part of the process to reduce fracture risk and also for comfort. And so in any of my children or young adults that are non-mobile, I think watching bone health is a really critical part to keeping kids out of the hospital and safe and comfortable.
Definitely.
Thank you. Ty, I'm going to circle back to you. I see you've got threads going on in the chat here, and I had another question, but maybe you can address some of those other issues as well. One person had specifically asked about your view on corpus colostomy surgery for refractory seizures, but I also see questions here about VNS and some other, the overall, the different modes of treatment for seizures. So maybe you can help us dive into that.
Sure. Yeah. In general, I think, there are three broad categories of ways we can treat seizures. And I was alluding a little bit to this in the chat, but they are using anti-seizure medications, and there are a lot of seizure medications that are out there, probably over about 20, and some are better for some seizure types than others. So that's where it's really important to kind of nail down what type of seizure person is having. But if medications aren't cutting it, then there are potentially other treatments that are out there, including things like diet therapy, like ketogenic diet, which is a high fat diet, very low protein and carbs, that really has to be done in management with a specialty team, like a ketogenic dietitian, neurologist has to be there with you. It's not like the keto diet books that you see like that are out in the bookstore that you can just like suddenly start yourself, because it's really a very strict therapy that requires a lot of monitoring, particularly for kids with epilepsy. But for some kids, it can be an effective therapy. And then the other therapy is surgery. Now, there are a variety of different surgeries that are out there that we have for children who have epilepsy. Some are in the brain and some are outside of the brain. So vagal nerve stimulator, VNS, is outside of the brain. It's a little coil that goes around the neck, or a nerve in the neck, and stimulates the vagus nerve, and that can help with seizures. There are resective surgeries, of course. So like if for kids who don't have Bpan, where we know their seizures are just coming from one spot in the brain, we often work those kids up to see if their seizures could be amenable to just resecting one part of the brain. But again, Bpan is a whole brain process, so that's generally not something we consider for folks with Bpan. But the corpus callosotomy question is a very good one too. That is a surgery that we often do. So what a corpus callosotomy is dividing basically the main white matter fibers that are connecting the hemisphere. So it's not actually getting into like the gray matter brain cells itself, but it's dividing like the big highway tracks that are connecting the hemispheres. And that's just not a new surgery. It's been around for many, many decades. And we found that generally it's most helpful for kids who have atonic or drop seizures. And I tend to use it in kids who are, so drop seizures are really quick. They're a very short seizure type. It's not like they're long seizures that are going into status epilepticus, but kids who are having drop seizures can hurt themselves. And that's kind of the biggest issue, is that they can hurt themselves and hit their heads or injure themselves. And for folks who are not responding to medication or maybe diet therapy, a corpus callosotomy can be a good option. It can certainly help with drop seizures and maybe some other seizure types.
VNS.
Yes,
VNS, yeah.
VNS. Yeah, I brought that up at the beginning, Jenny. But VNS is a great option. It's not intracranial, so it's not in your brain. It's outside of your brain. Again, it's a little coil around nerve in your neck that provides intermittent kind of pulsating stimulation. And that can be helpful. I think, I put in the statistics there that are generally published, but it's something around like about 50% of kids see a seizure frequency reduction of 50% or more. And so it's generally not a cure-all. Most kids that I have are not on just VNS therapy, and that's it. Usually they're on some combination of medication and VNS, but for kids who VNS is helpful, it may allow them to come off of one seizure medication if they're on multiple seizure medications, one or more, and that can help with their quality of life. There's one last question there. Feedback on VNS potentially impacting vocal production. Usually that's just, you're right, the vagus nerve has some influence on our vocal quality, but usually that's a very stimulation sensitive thing, meaning that we can adjust the stimulation so that it's not impacting someone's voice or not causing them kind of throat irritation. And that's something that we can do just by dialing the settings up and down in the office and seeing what's tolerated and what's not. So it's generally not a long-term thing that it's going to cause vocal issues.
Okay, thank you. Susan, I'm going to ask you to start with this next one. Others can certainly join in. Many families whose daughters are coming of age feel like they're not equipped to manage menstruation, either because of cognitive issues or fine motor limitations that just make it really hard. and they're getting good counsel about their options in terms of, managing their girls so they don't menstruate monthly in terms of, Depo-Provera, IUD, et cetera. But the question they're having trouble getting answered is, with Bpan specifically, when we see premature adrenarche and we see other endocrine changes, is there anything they should be concerned about with that sort of management? Is one preferable to the other for that reason? I'm not sure we have answers to this, but maybe we have a gut feeling or a sense.
Okay, yeah, I can take a crack at it within the limits of my knowledge, which are vast. The limits, not my knowledge. I don't. So we don't know the full spectrum of endocrine health in people with Bpan. What we do know is that a significant number of people with Bpan have early, sort of one aspect of puberty happens early, often happens early. It doesn't in everybody, but it does in many. And that is specifically the adrenal glands, these little glands associated with your kidneys that are part of the endocrine system. They send an early signal for pubic hair growth and for stinky armpits. We say axillary sweat odor, but you'll know it as stinky armpits. And that can happen as early as infancy. It can happen in a young baby to have early pubic hair. And that can be sort of a little bit shocking to a parent, but it's not a health problem for your child. It tells us that there's something awry in the brain. And we know that, right? Because we know they have Bpan because you're here at this meeting and in this session. And so there's no news in that really. The question is whether there is more of a puberty or other kind of endocrine health problem. And there's a scientist in Texas who has an interest in this. She's actually taken quite a significant interest in the issues of weight management in Bpan and weight health in Bpan. She's been trying to get funded to do actually an endocrine natural history study, or to do an endocrine kind of assessment. But and so we don't know the full answer to whether there are other aspects of puberty that are problematic. I will tell you that from just the general sense I have from what I've learned from you all, so you are our teachers on these fronts, your kids are our teachers, is that there don't seem to be significant problems with puberty otherwise. So we know there's the pubic hair and armpit thing, but there doesn't seem to be early general puberty. That is the changing of the organs and the maturity of a person's reproductive system. And so therefore, in answer to that question, I don't think that there's anything about Bpan that would, the Bpan endocrine system that would change the way that one would sort of try to control or better control menstruation. And I'm going to defer now to my colleague, Penny, who, as an adult neurologist, taking care of intellectually disabled people for adults to a much greater extent than I, will probably have some other things to contribute.
Actually, not that much. I mean, I think in intellectually disabled adults, it is I think there are effective means of suppressing menstruation, and that is a choice that families often do wind up making. And this is a sensitive and touchy topic, but I think that it is also important as a young woman matures to consider risks of pregnancy, unintended pregnancies, I think need to be considered. And so that is always worth having a very frank discussion about ways you can protect your child, in your adult child, in a variety of settings. As a a young woman with Bpan may not be with her family quite so much of the time for a variety of reasons. I do think that that's a topic that should be an open topic of discussion with her care team. I don't really have anything much more specific to say about management of menstruation. I think what we've seen from the families that we've interacted with is almost, and Allison, you can weigh in on this too, I think it's almost universally, they have decided to go with implantable forms of birth control that effectively suppress menstruation. But it is actually more often falls in the pediatric realm, I think, because, you know, kids begin menstruating well before they come into my adult realm. We see them in the peds clinic. So I actually think the peds folks are probably better placed to comment on that. Jenny, do you have anything to add? Don't want to belabor the point, but just
I don't know how much I have to add. Yeah, I'm gonna not.
Okay. Well, maybe we'll wrap that one up then.
Thank you. I had another one on my list that's coming through the chat as well. So clearly people want to know. So my question on my list, and this can maybe go to Laura and Jenny to start with, and then maybe Penny can talk about it in adults. Constipation and bowel regimen. You know, I think a lot of people are chasing this. They are on this cycle of glycerin suppositories and not being able to keep somebody regular, and that can be problematic for other reasons. What do you recommend? How should parents approach this systematically and try to keep their kids kind of steady?
Oh, I'm happy to take this one.
Okay.
we're big on the poop in our clinic. I think constipation is really a core part of the problems that a child will encounter day to day, right? Increased difficulty with pooping and constipation can lead to urinary retention, which can lead to potentially urosepsis and hospitalization. I've seen that many times. It can lead to more autonomic instability, dystonia, worsening, tone, because if your body is uncomfortable, it's going to manifest in lots of different ways. I think why children with Bpan in particular have such constipation, I don't have a specific answer, but I know across the board, a lot of that has to do with overall tone. And the tone on the outside of your body and kind of what your muscle tension is, oftentimes reflects the tone on the inside of your body and how well you can move along your food. And so when children have tone abnormalities on the outside, I almost always see them have severe constipation. And the constipation game is a prevention game. It is not a treatment game. We have to stop it from happening in the first place rather than trying to fix the problem when it happens. So if your child is stooling regularly, that is not a time to stop your bowel regimen. That's the time to say, hey, we finally hit upon the right mix of medications. I'm going to continue this, right? So I think we do a lot of reaction with constipation because we think it's a temporary problem. It's a long-standing problem being driven from Bpan itself. And so it's really something we need a regimen. We got to stick to it. It is something we spend easily 3/4 of our clinic visit talking about is poop, which is why I love having a complex care pediatrician on my team. So I get to have Dr. Jaffe talk about poop, but I do it in most of my visits too. So I think the answer to Christina's question is really, I think it fundamentally comes down to a neuronal and a brain problem, and probably driven by the tone.
Anybody else want to add to the poop talk?
Well, in adults, I think that it is also driven by tone abnormalities. But I think the issue of autonomic instability and the role of medications becomes even more important. So the gut transit time slows down in Parkinson's disease, and it definitely does in Bpan too. And I would just really second Laura's comment about if somebody is having trouble, pain from constipation, or because they're struggling to pass a stool, that can really send their dystonia through the roof. And then you're into this cycle. Certainly in Pcan, and I suspect in Bpan too, I do think that that could be a precipitant in an adult patient for a dystonic storm or something along sort of on that spectrum. And so, and I'd also just second the management prevention is the way to go to the extent possible. So stool softening regimens, bulking regimens, plenty of making sure there's adequate water in the diet. All of those types of measures are probably more important than stimulant laxatives, because as soon as you get on the stimulant laxative train, it's much harder to back away from that without immediately jumping right back into a cycle of constipation. Sometimes people tell us that their child or adult is stooling regularly, but they might still have a yard of poop in their colon that they're stooling around. They might even have loose stools around that. And so just because somebody is having small regular poops, I'm not sure that that necessarily means they don't have some core problem of constipation. And if you're seeing, dystonia going out of control every time they need to stool, that might be something to discuss with their care team.
So we've got the follow-up questions rolling in. This is clearly an issue. I think we already knew that. So someone who's 23 and is thought not to have constipation, but struggles regularly to pass feces, is that a separate issue? Is that this part of the same issue? And how might that be addressed?
Yeah, I think that's going to be specific enough that it might need to be something that, is talked about offline or with the person's own provider. When somebody becomes very, very deconditioned, I think that, muscle tone, like sphincter tone and such, may change. I also think, these fluctuations in dopamine levels can play a role there. And in very selected circumstances, there is a role for stimulation types of laxatives in that setting. But I would be very reluctant to make any kind of recommendation on that front without understanding what might be going on, because this might be an instance where she doesn't seem to be constipated, but she's actually got a big goombar of stool in there, and she's struggling to try to poop little bullets around it. Sorry to get graphic here, but
we're all friends.
we're all friends, and I think everybody whose faces I can see right now spends a lot of time talking about poop. So. All
right, I'm going to shift gears. Only because I saw a couple of other questions come in that are really good ones. One of them that I'm surprised hadn't already come up. And I'm not sure who to direct this one to. Maybe we can start with Penny, because we've talked about this at OHSU. My son's liver enzymes are very high from time to time. Is this a problem? Is this common in Bpan?
Well, actually, Allison, I would have you start with what we've just kind of what we've observed.
Yeah, so what we've observed, especially early on when we were combing through medical records from our first identified cases of Bpan, we did see these occasional liver enzyme elevations. And the first question is it from a seizure medication? Because we are careful about that. But we also saw them happening in kids who were on no medications whatsoever. And it was sort of vexing enough that I remember one child in particular, it had a liver biopsy trying to investigate this. It seems to be innocuous. We do see this happen from time to time. We see it in PLAN as well, another NBIA disorder. And I'm not going to try to go into the details of explaining it. Maybe Penny can address that a little bit more, but we don't think it's something to be overly concerned about, especially if you're not on seizure medications that raise that concern as well.
I would just add that I do think it is telling us something about the pathophysiology, the origins and the pathways in Bpan. And so I think the fact that we have detected it, that we're looking for it actively, it is an important thing that is coming out of the natural history study. in the records that we've obtained over the years just on clinical consults. I think, the more data we get on this, the more likely we are to be able to see a meaningful pattern and to have a pathway, a rational pathway to investigate what exactly it is telling us. I really don't have any doubt that there's a story there. I don't think we know quite enough at this point to know exactly what is going on. Susan is welcome to chime in if she wants to, but I see she's pretty active on the chat as well.
So we've got a lot of side conversations going on here. So there is one question from Sarah in the chat that I wanted to try to address. I'm going to ask the pediatricians on the panel to maybe think about this and comment. And Sarah, I might need you to clarify what you're asking. But it says published findings in Bpan have indicated that elevated serum LDH and serum neuron specific, maybe it's supposed to say marker, are an indicator of early neuronal and cardiovascular injury. So we have this concern of early neuronal and cardiovascular injury. How might hypoxia and reduced oxygen levels, chronic or intermittent, affect function? I know Sarah has a young child, so that's why I asked maybe the pediatricians to comment on this first. I don't know if Jenny or Laura.
Susan, do you have anything?
So let me frame what I think I'm hearing in the question, which is we know that there's injury to brain cells. We don't need any kind of a marker to tell us that. We know that based on looking at the kids. And the question seems to be asking, is hypoxia on top of that? Hypoxia maybe from seizures, hypoxia maybe from changes in blood pressure, the dysautonomia, the autonomic dysfunction. Are those contributing? There's not a data answer to the question. There's not a study that can answer that question. Hypoxia, even mild, frequent hypoxia, is a stress to the body. It would be in my body as well as in the body of a person with Bpan. And so I would say that, we should be doing, what is reasonable to avoid hypoxia in a person with Bpan, as we would in most people with most disorders. I may have misunderstood the question, but that was my understanding of the question. Others may want to add in.
Just to, there was a question earlier, which I think just got answered in the chat, about, other organs in the body being affected by WDR mutations, by Bpan in somebody who has Bpan. And as I think Susan responded, we don't see obvious abnormalities in heart function, in liver function, in kidney function. Like the rest of the body seems to work really pretty well. I think what we might be seeing in these liver function enzymes is evidence of a little tiny bit of Bpan affecting the liver. That's putting it pretty simplistically, but these things like LDH, not so much neuron-specific enolase, which is the one that Sarah was referencing, which is a neuronal marker. But I think these, the other liver function enzymes that we see, just small elevations in, but enough to get people's attention, maybe that is telling us that, well, maybe Bpan does affect the liver a bit. We don't see people with frank liver failure or the kinds of problems in their liver that make their skin yellow or, cause obvious symptoms. And so right now, to the best of our knowledge today in 2021, we're observing it. We think it's going to tell us something sooner or later. We don't know where yet. We don't know where we're going with it yet. That would be my best guess.
Thanks, Penny. Susan, because you talked about iron earlier, I'm going to ask you to handle one follow-up here to the menstruation question. It's apparent with concern about suppressing menstruation because that's the body's natural way of getting rid of some iron every month. And, you already addressed how much we do or don't worry about iron, but maybe you can kind of address that one specifically.
Yeah, so there are, because of the genetics of Bpan, there are differences in how the disease manifests in males and females, but I would remind you all that men don't menstruate, and they don't have more iron in their brain, and the brain in Bpan and in the other NBIA disorders, as best we can tell, takes as much iron as the disease process, this kind of disordered disease process is instructing it to take. So I can't remember if I mentioned this in this session or in the session from yesterday, one of the sessions from yesterday, but our current understanding of the iron mismanagement problem is that the brain cells actually think that there isn't enough iron. And that's because the iron isn't in a form where the brain can take up, the brain cells can use the iron. Now, this paper we've discussed briefly this morning, that may suggest that it's actually a different kind of a pathway, a different kind of a mechanism, but it may, so if there is not enough useful iron for the brain, it thinks it needs more. And so it signals, hey, send me more, even at the expense of the rest of the body. So you can have actually quite severe iron deficiency anemia in your bone marrow, in the rest of your body, in your liver, in your blood cells, and your brain has just taken up everything that it thinks it needs. And so I wouldn't worry about stopping menstruation having any influence on the amount of iron that goes into brain and Bpan.
Thank you. I'm going to shift gears a little bit. We had a couple of important questions that I wanted to address, and I think several panel members can contribute to this, and several parents deal with this. So the question was, please comment on the challenge of having specialists who won't take the time to learn about Bpan, or who aren't curious or won't think outside the box. I think it's a good reminder that, some families are in big cities, some are in rural areas where they have to go hours to get care. As Penny said, maybe we'll be doing more of that remotely, but how can they, as physicians, what advice do you have for them on this issue?
Give me their phone number and I'll talk to them. I'll give them a spanking. Just kidding. Don't do that.
I'll take a gentler approach. How about that? I think with Jenny's consensus paper, it really is going to be the first step for us getting this information disseminated to the broader community, to empowering local physicians to feel comfortable about what the right steps are. Outside of the big centers, I'll give them a little bit of slack. There's not a lot published out there about how to help children with Bpan because it is so rare and there hasn't been the consensus guidelines. So I would say take this paper, or take the knowledge that this paper exists once it's published, to your local providers. And then I know our group, and I'm sure it's true with the other groups as well, if your providers message us, we can offer conversations between physicians, right? We cannot offer patient level advice if we haven't seen you, but doctors can talk to doctors. And so creating this network of people that feel comfortable is really, really important. And I would also do the big flag I want to raise is I also think we're reaching families too late, and we're identifying Bpan much too late. And so I think even taking it back to your pediatrician, raising awareness that mild developmental delay and autistic features, particularly in girls, people should have this on their differentials. They should be thinking about it much earlier, and that we are waiting years, if not decades, to get to a diagnosis, let alone to get to a specialty center. And I see that as being a major issue and barrier too.
I think what's encouraging in my world, which is an epilepsy world, is that we're doing a lot of genetic testing these days for epilepsy and early onset epilepsy, and WDR45 is being added to epilepsy panels. So much to Laura's point, we're detecting cases earlier. And I think, whereas, we may have not detected cases until later in childhood or even in adulthood. Now we're detecting cases earlier and earlier, and some places are setting up, you know, specialty genetics clinics or specialty neurogenetics clinics to try to answer some of these, or to not answer some of these questions, but to, you know, become specialty centers. So I think things are evolving rapidly over time, and, you know, what we say today will become irrelevant next year. But I'm encouraged that, you know, that this gene is being added to a lot of epilepsy panels and we're seeing it identified earlier.
Yeah, if we were to track the kind of average age of first contact with our team since the time of the gene discovery, it has totally peeled down. You know, we routinely hear from people now in the first couple of years of life, and it is almost always following whole exome sequencing or epilepsy panel testing, sometimes RET panel testing. So after the gene discovery, one of the things that we pushed for, you know, called for openly in the first publication of the paper, and then, you know, with active outreach, was to get this gene added to epilepsy panels and to RET panels. And it's definitely, that's the way it's going. So we're hearing from people really, really early now, I think, which is great.
Yeah, I agree with you, Penny, because I'm on the front line. I end up talking to a lot of these people first, and it's floored me how, you know, 18 months, kids under 2 now, 2 to 3 we're hearing from. And I think we still see the other end. We see adults who have been very stable, but when they start to enter a period of decline and get a new MRI, they're being more aggressively tested now as well. These are people in their 20s and 30s who never had gene testing, who are being tested for the first time. So we still see kind of this bimodal distribution, I guess, of that.
Yeah. Yeah.
Susan, did you want to add something else?
Yeah, I wanted to give a call out to Sunita Venkataswaran is actually in. She looks like she's in the audience, but she could be on the expert panel as well. Sunita is a child neurologist in Ottawa, and actually is probably, you know, she's another North American Bpan expert. And if you're in Canada, she's someone who your Canadian docs, so though you're welcome to call the US too, but she's a great resource with quite a lot of experience with taking care of a number of children with Bpan and other NBIA disorders. A great resource for those in Canada. Yeah, so keep her in mind as well.
For sure. Seeing a couple questions in the chat about, you know, from Mike, how many Bpan patients have we identified worldwide? What percentage are in the natural history study? Have the diagnoses grown globally? I think we answered that. That's yes. Mike, getting to your question, because I'm on the front line, I can tackle that one too, but it's mostly, we don't really know. I mean, worldwide is very difficult. There are some countries, continents we literally never hear from. And there are most certainly kids with Bpan there, they're just not being diagnosed. So there's bias in that. But I think, you know, worldwide, I'm certain that we're in the hundreds, and I can tell you, I hear from a new family pretty much every week now, either from the US or Europe, Australia, New Zealand, Israel, you know, certain countries that are doing more testing. So in our natural history study, we're well over 100. I think we're around 125, 130 now. I don't know what percentage of the total that is, but I'm really encouraged that we are capturing these really little ones now who are coming in at the beginning, who we can track long term.
And if there's any question, Bpan is the most common form of NBIA, most common NBIA disorder. It's very clear.
I think just by the number of participants in each of our clinical sessions, you can tell that.
Yeah, there was a paper published, I think 2 days ago, that about one of the other NBIA disorders that referred to it as the most common NBIA disorder, and they are wrong.
And there's a question here too about, has Bpan Ready been impacted by the pandemic? I can address that, and happily I can tell you, not really, because these NBIA disorders are so ultra rare. We had already created a study design that was remote. We had already had systems in place for collecting data online and over the phone with all of you, not just for Bpan, but for PCAN and PLAN, and for our clinical trial that's ongoing as well. We have been very fortunate to not be interrupted really at all, even when we're all working from home for the most part, or going in just as needed. So I can reassure you that our data is intact. Things have been happening on time. We've been incredibly happy and grateful about that. And then we also had a few questions here about bone health. I'm trying to go back through the chat. Are there any general recommendations, either in children or adults, in terms of vitamin D, calcium, weight bearing? I know, Jenny, you talked about this yesterday. Maybe you could start.
Yeah, I mean, I think any kid with difficulties with motor skills or epilepsy, or who are on seizure medications, are at increased risk for fracture as they get older. And starting early with preventing that is ideal. So weight bearing as long as possible. And even if kids are not ambulatory, they can still be using standers or gait trainers to build that bone density. It's really important. And then, yeah, in general, calcium and vitamin D, we want to make sure the intake is adequate. And oftentimes, for my kids, I am recommending an additional vitamin D supplement if they're at risk for low vitamin D. And sometimes we check the levels, and if they're low, we supplement. Sometimes I just recommend a daily supplement, but I think everybody's approach might be a little different here. So in terms of how rigorously we check the levels. So yeah, you might get different answers from different people, and from an endocrinologist might tell you something a little different, but I do start paying attention pretty young to this, and ask and encourage adequate vitamin D and calcium intake.
Thank you.
Could we ask the Zoom tech to just make sure that Sunita's video can be turned on? And then if you can bring her to there she is. Yay. So there's Sunita. Sunita, is there anything we've said that you want to challenge or add to?
No, nothing to challenge. No, it's nice to hear that we're all doing, have the same approach and have the same multidisciplinary approach to our families. And so there's nothing I need to add at this point. It's been great to hear you all speak and hear all the wonderful questions from everyone.
Thanks, Sunita. It's good to see your face now. We had a follow-up question on bone, well, not really bone health, but bone age. And Penny, you and I have talked about this in the past. I know you were paying attention to it in our initial cohort. So someone with an advanced bone age, significantly higher than her biological age, and a little girl, and wondering if this hints to increased bone growth leading to less stable bones later in life. But I know we've also talked about this in the context of premature adrenarche and what's going on and with the endocrine system. Maybe you can comment on that. You're muted, Penny.
Sorry, I tried to pay attention to that. I don't think we've seen this really broadly. At least it's not reported, and that may just be that it's not being evaluated systematically. I think this is something that could come out of our endocrine colleague, who is interested in looking at weight and some other things, and we've encouraged her to think about expanding the scope of that endocrinologic evaluation. But I think that this is almost certainly is going to wind up being tied to the story around premature adrenarche and other endocrinologic derangements or abnormalities in Bpan. I think it requires a bit more systematic study to draw any conclusions about it. It is another place that, just to put in yet another plug for the natural history study, we collect systematic data in the natural history study, but we also are collecting medical records in an unbiased way, and we see things, hear things, that then leads to us trying to put in to the natural history study a more systematic approach to collecting those data. And this is one which is sort of in that simmering phase, I think, about figuring out what would be the best mechanism to put in a systematic way of capturing that. So stories not answered yet, but I think there is like the liver function abnormalities that we see, I think there is a story there, and I think it is ripe for study. And I think we're kind of on a path to doing that.
Thanks, Penny. We've got just a few minutes left, and I'm going to end on a really great and what I hope will be an uplifting question from Mike. And maybe Susan can start with this, and then others can chime in. In terms of research studies, everything that's going on in the Bpan world, what seems to be the most encouraging finding? What are we encouraged by right now, and we can move forward with?
This might be a round robin. We can all sort of speak to what we're most encouraged about. In fact, not just the speakers, but the families, because you're a big part of, as I said in the chat, what I'm most excited about. So, I wish I could say the 4 clinical trials looking at rational therapeutics, but that isn't the reality today. There is a path to getting there. And that path, unlike in all of the other NBIA disorders, that path has hundreds, if not thousands, of scientists working on it. I wish I could say they were specifically interested in Bpan, and if they knew about Bpan, they might be, but they're specifically interested in autophagy. And so there's a huge scientific community working on autophagy, and their work, whether they know it or not, will advance our knowledge base of Bpan in ways that will help us both understand the disease, but also get to a creative set of therapeutics. I made the point in the chat, but I'm just going to say it again. There's a talk today, I think, from a scientist from the Office of Rare Disease Research at NIH, who is advocating for the development of natural history studies, especially in rare diseases. And we've been beating this drum for years. I wish we had started 30 years ago, but we started more recently. I'm actually excited about the natural history data, and there is no community in which we have kind of more enthusiastic participation from a very early age than the Bpan community. So that also speaks to something, it sounds kind of trite to say it, but your energy and enthusiasm is a big part of what kind of, we feel that, and it's something that engenders energy and enthusiasm for us as well. And so these kinds of interactions that we're doing right here are something that I'm excited about. It sounds kind of simplistic, but it's also something that I think brings a lot of value for everybody. So pass the baton to others.
Penny, I think you're muted again, if those are your lips moving.
I was actually, Dr. Sid's talk about natural history studies is starting in about 5 minutes. I don't think I really have much to add to Susan's comments. I do think that the interest in autophagy, whether it's coming from Parkinson's researchers, Alzheimer's researchers, or rare disease researchers, it is a very, very fertile topic right now. And I think that is going to be our path forward. The smart researchers in Parkinson's, Alzheimer's, and other areas recognize that single gene disorders are often the most revealing about a given process that's leading to neurodegeneration. And if they are smart, they will pay attention to us, because we are a force to behold in the Bpan community, and nobody more so than you, the families. So more power to you, more power to us all, and onward.
Thank you. Amber, can I ask you to wrap this up for us and send us out?
Yes, thank you so much. I know that I learned a lot, and I'm sure that everybody else can say exactly the same. I know this is one of my favorite sessions of the conference every other year, and wish it was more often that we could all get together and discuss. So thank you all to the panelists. Thank you, Bpan community, for being here. And that is a wrap. I hope you enjoy the rest of the conference.
Thanks, everybody.
Thank you. Bye.
Bye-bye.